City is back, as you can hear, and he's enjoyed himself in those 4 weeks, City? It's been a long time, but you just
so that you can be happy and make it 5.
It's been like a month.
Yeah, it's just been a long time, but you've been chilling and enjoying yourself.
Oh, yes.
Yeah?
Yes.
All right. Our guest for the next hour is Dr. Mary Amuyunzu Nyamongo, who is... She is the founder director of what many things? Mary, what is it?
Just you massacred my name.
Okay, say it.
Amuyunzu Nyamongo.
There you
Mary.
go.
Yes.
There you go. Mary Amuyunzu Nyamongo. I'm sorry, I said Nyamongo.
You said many things.
Too many things.
Except
Too many
what you
things.
have said.
So here we go again. Our guest for the next hour is Dr. Mary Amuyunzu Nyamongo. She is the founder, director, and technical advisor at AIHD, African Institute for Health and Development. And she'll be here so we can talk about what you've been doing and your mantra, which is in Africa where people live in dignity.
Yes.
Aha. You'll tell us more about it. City is back. He has been away.
Okay.
While he was away, he was enjoying himself. City will give you the day's proverb. Every week he goes to an African country, he brings us proverbs. Now, he's going to give you a proverb from the Gambia. Your job, listen to the proverb and give us your interpretation of that proverb.
Okay.
Okay.
Was that part of the idea here?
Yeah, it was part of the brief.
Okay.
He who sleeps on a borrowed mat is sleeping on a cold, very cold ground.
Okay, from an anthropological interpretation, it means if you living on borrowed time, it will not be comfortable. If you don't own what you're using, you are at risk of being embarrassed. So it can be very cold. That's an anthropological interpretation. CT, what did the Gambians tell you? How did they interpret it for you?
Exactly the way you interpreted it.
Okay. So I wore my anthropological hat. And that's what I thought it meant. That if you are living on borrowed items, if what you're doing really doesn't suit you, it's time to move on to something that suits you.
Beautiful.
Yeah.
Beautiful.
The problem is sleeping on that mat and forgetting it's borrowed.
Yes. And being comfortable.
Yes, when the owner comes for it,
Yeah.
it means all along you didn't have a mat.
And you will hit the person. That's
Yes.
how you surely. Hata angenipatia notice.
Yes. Lakini ulikuwa umeomba.
The fact at the moment you borrowed, that was notice.
Yes.
Mary, tell us about AIHD.
Okay, so as you heard, I'm the founder director of the African Institute for Health and Development. We started this organization in 2004. I'm an anthropologist, so I did my initial studies, my first degree at the University of Nairobi. I graduated in 1989. And then I worked for KEMRI, for Kenya Medical Research Institute, for 7 years. And during that period of time, I did my PhD. STEM in anthropology from the University of Cambridge in the UK. And from KEMRI, I then joined AMREF Health Africa, where I did work on reproductive health, and then moved on to Population Council, and then did 2 years with the African Population and Health Research Center based here in Nairobi. But during that time, I was burdened with the fact that we do research, but does that research really inform our programs? Are we generating evidence that is used for programs? And secondly was, are we able to inform policy, engage at the policy level with the kind of work we do? So essentially, in 2004, the burden to also just start a Kenyan institution. A lot of these NGOs are started externally, and so I decided it's time. Let me start something, an institution where we provide dignity to our people. Ill health and poverty are dehumanizing. So we talk to people about, do you understand nutrition? Your child is malnourished. And a mother tells you, yes, I know, because I can't afford food. I know what to give my child. But how do I go about getting the right ingredients to feed my child if I'm poor? In this country, as we speak, city, 15 counties are still practicing open defecation, really, in 2024. And so some of these really burden me, and I've worked a lot in the poverty space where we see a lot of diseases that are poverty diseases. Eric, if you know, we still have burdened with the intestinal worms. Mignon. There was an advert when we were younger where they were asking, Siti, uko na mignon? Eric, uko na mignon? Nasema, mimi siwezi kuwa na mignon.
Je, Manduka, uko na mignon?
Uko na mignon? That one. And so, just to recognize that you can actually eliminate mignon through simple actions such as access to clean water, use of latrines. And yet, in 2024, 25 million Kenyans are at risk of intestinal worms. If you go to Western Kenya, a high population is at risk of bilharzia, which is a water-related disease. And so, as we think about poverty and as we think about dignity, we just realize that some of these conditions really require more investment in prevention, a bit of investment in and a lot of investment in education where people know what to do, but at the same time, just investments in these key infrastructural investments that really would make a difference. And so from 2004, we have, I was the executive director for the institution for 13 years. And in 2017, I stepped aside for two reasons. One, when you start an institution, the risk of you overstaying your usefulness is really high. So step aside, you assess the viability of the institution. You also bring in people with new vision. Since 2004, by 2015, your vision is beginning to get a bit old. And you just need new people, new blood in the system so that they can run the organization. But I stayed on as a technical advisor to the Institute. We do a lot of work currently in neglected tropical diseases. I talked about schistosomiasis earlier, which is bilharzia. I've talked about soil-transmitted ehrlichiosis, intestinal worms, these Muzungu names. We also work on elephantiasis, which is lymphatic filariasis, which affects mainly the coastal region. We do work on trachoma and other neglected tropical diseases. They are called neglected because, one, they affect mainly the poor and the vulnerable. And two, because access to treatment and test kits is limited because of the numbers of people affected. So over the years, Kenya as a country has committed to eliminating some of these diseases. We have leprosy, which is an old disease that we all know about. In the past, we used to have what we call African sleeping sickness, African trypanosomiasis, which is now we are eliminating as a country. Onchocerciasis, river blindness, was also endemic in the Western Belt. We are assumed to have eliminated it in 1950s through vector actions, but we're now seeking to be certified for elimination. So that's one part of what the institution does. We work with the Ministry of Health. We also work in partnership with other NGOs, including AMREF, Health Africa, Kenya Wash Alliance, and others. Another piece of work we do, which is interesting, is on non-communicable diseases. And all of us know. I think even you here, you know somebody who has cancer, diabetes, hypertension, or we are raising money for a patient. And over the last 10 years or so, we've seen a real increase in all areas of NCDs. And again, We go back to lifestyle, we go back to prevention, we go back to access to treatment. Currently, I'm the national chair of the NCD Alliance of Kenya, which is an NGO that brings together alliances and professional organizations, professionals working in NCDs. And so as a country, this is an area of need where we are seeing children with sickle cell, children with type 1 diabetes, type 2 diabetes is on the rise, and some of these are really due to lifestyle. Mental health is also another area that has, we are beginning to recognize that it's important for us to focus on mental health. Recently, there was a young doctor who committed suicide. I think when you begin to lose professionals to mental illness, then as a country we need to sit back and ask ourselves, what are we doing to safeguard the lives of these people?
Right.
So many things. Do you have a question for me before I continue? I can continue rambling for an hour.
It's interesting that even as the work that you do are looking towards, development markers, milestones, crossing over, which is very important. But then in order to find solutions to some of these things, I think that understanding of why then is very important. I'm looking at some of the things that you talk about and some of the words that you're using: risk, poverty, health, these issues, that in 2024 there's still some problems that we have that, in my opinion, we shouldn't. Why do we still have such high levels of underdevelopment in these sectors at this stage? Why?
I think it's a question that we should all be asking. Under the MDGs, we made good progress towards attaining some of the MDGs, but we still have high deficiency of water, access to clean water. We still have deficiency with sanitation and hygiene. And I think when you think about our investments as a country, are we investing in prevention? Even at the county level, when county governments and our governors took over, even within the health sector, we saw a lot of buildings. If you go to Homa Bay, I'm sure you're aware of our western region, which I'm very familiar with. We saw a lot of construction, hospitals. We saw a lot of infrastructural investments. How much are we investing in water? How much are we investing in food and nutrition? How much are we investing in facilities that would help people be physically active, if you're looking at NCDs? So you have a lot of questions around what are we as a country investing in. Even if you go to a health facility, if I go back to the NCDs, just screening for diabetes, screening for hypertension, screening for other conditions that if they are caught early, we can actually deal with them. And then the other elements are around how we are understanding community level contexts that predispose people to some of these conditions. How are we dealing in mental health? How are we dealing with stigma? How are we dealing with making sure that people who have these conditions really get adequate care? So I think, Eric, if you look around our country, we speak, we act well, but when it comes to the actual investments in areas that would make a difference, then there is a gap.
So have you been able to establish why? Because like you said, you painted that picture very well and talked about your own research and working with the research institutions, and what was paining you was seeing the bulk of good research coming out of the communities, but then there's a huge gap between that and programs. And you said, let's form this institute that then bridges this gap. But were you able to establish why there's this gap? Why is it that our research, because there's plenty.
There's plenty.
Why is it that research does not inform policy, does not inform programs?
I'm not even sure that it doesn't inform policy or programs. There's a lot of policies in this country. There's a policy on everything.
Yes.
Latiff, there's a policy on pesticides. There's a policy on environment. There's a policy on cancer. There are policies on they are really good policies. The biggest challenge we have is the link between policy and implementation. And so if, for instance, we know, we even on the Sustainable Development Goals, we have signed off them. We are talking about increasing access to water. We are talking about eliminating NTDs. We are part and parcel of that process. But if we still have deficiencies in hygiene, if we still have households that do not have access to water, if women are working 2 hours in Turkana to get to water, how much of that water is used at the domestic level? So unless we really, and we know, that's why in this country we have open defecation-free activities. Why? Because we know that if we deal with hygiene, if we resolve this issue, we'll resolve the issues of neglected tropical diseases, a lot of the waterborne diseases. And therefore, I think the gap is in implementation. And
yet,
this is, yes.
And yet,
yes,
the preventative aspect of healthcare is a lot cheaper than the curative.
But how much do we put on prevention?
How much do we actually spend? Let's talk about the holistic look at what is spent on health, generally speaking. You actually got it right. When you talk of buildings, it's not just a structure. It is where money can be expended. Okay?
Yes.
Now, buildings don't cure people. Buildings don't make people well. And if you're talking about the fundamentals of public health, you don't actually need those buildings to ensure that these things get done. The question I would ask is, for each of those huge structures that you put up in, say, the county headquarters, how many clinics that would actually meet the needs of the individual in those far-flung places within the county could that money have put up?
Yeah, but when you bring up that issue, even within, let's even move from the structures, of the health budget, how much is allocated to prevention? So how much goes to curative and how much goes to prevention? And that's where the disconnect begins. If, for instance, 5% goes to prevention, let's even say 15%, which is very high. The only time in this country where we had a focus on prevention was when we had the two ministers, if you remember. You had
health,
the medical...
Public health and medical services.
Yes. And then we had a lot more focus on public health. But over time, and you realize this, that even for hypertension and cancer cases, by the time people get to a facility, it's already too late. We are always told it's already too late. How would you capture it earlier? One is a health facility issue, but the other issue is just access to screening, educating, providing information to families. As Africans, we are also very scared of going to just to screen.
Just because what if it's there?
You go to hospital, you are well. I just want you to look at, check me out, make sure I'm okay. Especially men, they do not do that very easily. We have opportunities, especially if we have kids, to go. But just encouraging, sensitizing communities and individuals to just go for screening is something that has shown, if it's caught early, if you go into a facility and you are pre-diabetic, then you are able to prevent. Or if you go early, you are able to deal with it. But by the time we are seeking healthcare, it's too late. And even when we go to the health facility, the readiness of the health facility to support you is limited because of the infrastructural deficiencies we have in some of our facilities. So it's a whole continuum of missing links, gaps in the systems that continue to bedevil our health in this country.
Everybody knows.
And we know.
Right?
Yes.
Everybody who's in a decision-making position knows. We are still in this conversation, on how we then link every bit of knowledge that we have into actual realization of programs that make sense, that mean something. In these many years since 2004, when you started AIHD, what have you seen in terms of difference? Is it communities that did not know? Is it because we've had arguments coming from people, especially politicians, that if I put my budget on preventive, people do not see what preventive it is. And somebody else goes and builds a hospital. The guy who builds a hospital gets more mileage than this one who decided that, I'm putting my money into cutting grass, into draining swamps, into doing all those things. Is it a lack of knowledge by the people, or lack of connection? Or is it, why is this? I'm still trying to figure out what's our problem.
Yeah, it's a big question. I think politicians are one segment of players in this, and then the administrators, the decision makers within the health system are another player. You have the NGOs, you have the communities themselves, and so I think is a meeting of minds at some point where we consider prevention and health promotion as key strategies. And I think we've come around. We are beginning to recognize a lot more the value of prevention, especially when it comes to, and we've seen a bit more of this within the NCD space, the non-communicable space, where screening is getting a little bit more normalized in some settings, where people living with NCDs have really come up as a group to begin to encourage other people to adapt more preventive lifestyles. We've seen, especially in urban areas, when you wake up a bit early, like you come here very early, you'll see a lot of people now taking up physical activity. So at an individual level, we are seeing a lot more consciousness towards healthy living. But the other challenge we're having is now increased access to poor quality foods. We buy air for children, those yellow things in packets. We are a little bit more...
What are those?
Those little yellow things you buy for children in the supermarkets, those crisps and other things.
Oh, that are full of air. 80%
full
air.
Of air. It's 80% air.
Tomatoes.
Yeah.
Potatoes.
So those really are... those are some of the challenges we're beginning to see that are permeating our diets, especially for young people, that are potentially harmful for health. So you've seen some positivity, but when it comes to, if you're looking at the risk factors for non-communicable diseases, we're seeing an uptake of physical activity, but we are also seeing a decline in terms of access to quality food, diets, and then alcohol use has just gone up also, new products within the tobacco space. And so the prevention agenda really needs to be stepped up, so that we can control what needs to be controlled from a population level. And some of these things, I could say I'll stop smoking, but it's not a population activity. It's a very individual action. And so from a population level, we need to look at some of these risks, some of these drivers to these diseases, and act on them collectively.
Right.
So we see... Senator Muma has a bill on tobacco and especially the new products within the tobacco space. We are still grappling, Eric, with advertising of alcohol. The billboards in this country are just... everywhere you go, somebody's dancing with somebody and they're taking serious alcohol. I mean, what are we doing? What are we communicating to children? So there are gains, but we're experiencing quite a bit of losses.
You asked a question.
Yes.
The budget that we have for prevention.
Yes.
10 years ago, there was a study done in the same Homa Bay County by a certain lady by the name of Professor Emarisiana Onono.
Okay.
She is now the Deputy Director General at Kemri. To ICCM, Integrated Case Management, Integrated Community Case Management, ICCM. They were trying to determine something very simple. How it is you could train community health volunteers to be able to diagnose and treat malaria, pneumonia, diarrhea.
Yes.
Okay? They trained 2,600 community health workers. Study took place 3 to 4 years. They were paying these community health volunteers a stipend of 2,000 shillings.
Per what?
Per month. Because the volunteers just within their setting, that was just to help you move around, 2,000 shillings. Okay? The understanding was after the study was finished, the county government would be able to take over to pay just the 2,000. Okay? Now, what is of interest is just the numbers that they saw. The sum total was they actually prevented hospital attendance by 75%, documented, meaning it worked. We now have people we call community health promoters who are trained. The same department, the same center that Marisiana belongs to in Kemri also had a care and treatment program called the FACES program. Now they trained community health workers. They even had a curriculum for training them. And the understanding of how it is you can actually get lay people to understand just fundamentals that don't necessarily need you to go to medical school. Okay? The cost of maintaining these people was minuscule. The county of Homa Bay was not able to pay the 2,000 to keep these people, and they were trained.
Yeah.
Maybe now with the community health promoters that have come up, maybe they've been engaged, but they were all over. So that cost is not something that anybody can tell you they can't afford.
There is argument in terms of sustainability.
Really?
That is the argument. Has been an argument. But I think the Kenya government now is paying...
Mary.
Yes.
I know the argument.
Yes.
I've heard it.
Yeah.
Sustainability.
Yes. That's the argument.
If it is the lamest, weakest, lopsided argument I've ever come across. For a simple reason, you are looking at just the aspect of reducing people who actually come to hospital for this costly care. Not even complicated. At 2,000 bob a pop.
So the disconnect is the cost effectiveness. Have we really sat down and said, if we pay the community health promoters 2,000 a month,
that was 10
how
years
much?
ago.
No, the disconnect now from a policy making perspective. I agree with you. It's cost effective to have community health promoters or health workers being the first point of call for communities in terms of prevention, in terms of early diagnosis. That argument is done. We know. But have we said, if we do that at a national level, this is how much we'll prevent, this is how much we'll save from actually direct funding of health facilities. That argument is there. However, our funding, our health financing model is basically aligned towards curative. That is the
It is
gap.
purposefully aligned towards curative.
Why? By who? By the merchants?
No.
Is it commercial interests?
It is commercial interest, but it isn't by the merchants. It is by the policymakers. Because as Mary is speaking, I'm asking myself, if you have a study that has shown you that it stopped 75% of those who would have gone to hospital
Did not go.
Surely, is it difficult to cost that saving? Is it really difficult? It is not difficult.
But see, now the government is actually supposed to pay community health promoters 2,000 shillings a month.
Yes.
That was 10 years ago. We are still paying them 2,000 shillings today. But it's something.
Okay.
If we pay it consistently, if you pay it long term, and you are it's predictable for them. You see, the problem we have is this government will come in and say we'll pay every month 2,000. Will the next government continue that? Will we stop? Are all counties committed to doing this? We do mass drug administration for schistosomiasis and soil transmitted ailments. We use community health promoters. So in the past, we've been paying. But are we now saying that because we have community health promoters, we can use them to distribute these drugs, which will make it cheaper and easier for us to access communities without having to pay extra to ensure that these programs run? That is the challenge. Mary,
where exactly is the challenge? Because what you're saying, in an essence,
Yes.
seems to answer the question that is being asked. So where exactly do you say the challenge
I think the challenge has always been,
Yes.
in the long term,
Yes.
can the counties commit? Do they have resources to do
No,
this?
do they have the will?
In the long term.
Do they have the will?
Do they have the will? But at the same time, we know our country. Would they have the resources to commit long term?
Okay.
The will to commit long term.
Sure.
I think we continue to ask these questions. We know it's beneficial. We know for human beings, if you prevent, then you are also preventing ill health among people. You are also building the human capacities in this country. But where is the gap?
Is it not a composite, though, Mary, of all of these things? That when you talk about priority making, when you talk about will, whether it's a political goodwill, whether you talk about the availability of resources, it's composite of all of these things. But then I struggle to be at a place whereby, again, I mean, I think one of the very first things that you've said has really stuck in my mind today. And I say, no, that we should not be there today.
Yeah.
We should not. And that availability of resources has usually been has carried the burden for what willpower and priority making should actually carry.
Yep.
That unavailability of resources has been, the scapegoat for what the responsibility should be placed on these other two things. But really, we have a lot of the burden of healthcare being shouldered by external
individuals.
parties.
Yes.
By private organizations. Yourself.
Donors.
By donors, yeah.
Until government, sorry to say, maybe not sorry, has gotten comfortable with not prioritizing something like healthcare. Look at some of the, diseases that you speak of, which some countries forgot about
Many
decades
years
ago,
that
we're still dealing with today.
Mm-hmm.
And that should not be the case. But then we blame it on this poster child of unavailability of resources. But it should not be the case. So the question is, do we really feel that nations, especially on this side of the divide, do we really feel that nations can actually take the burden that healthcare poses on society and deal with it?
Yes.
Can we?
I think I'm convinced we can. Over the years, I know for the diseases which we are interested in, we really donor dependent. That's the challenge in this country. Our health budget has been around 7% for a long time, national health budget. We signed off Abuja for 15%. We've never reached the 15%. Do we have the resources to do this? Yes. Can we do this? Yes. What amount of wastage within the health system? Again, the figures differ, but it's documented that of the money we get, a big proportion of it is not used at the end of the year. Some of it is wasted within the system. And so we just feel that if
or stolen.
We put all stolen. If we put our act together, we can do better, Eric.
Have you engaged with governors?
Yes, all the work we do, we work with governors.
Okay.
And
when you sit across the table with governors, let's say, the Committee on Health or just individual governors, what do you read from them? What is their perception of the needs for health and the needs to direct investment in health?
When you speak to individuals, they recognize the need, and I'll be quick to say some counties have started putting resources, especially with neglected tropical diseases. We work in Kakamega, Busia, Kakamega, Trans Nzoia, Vihiga, and Bungoma. They have now allocated funds for neglected tropical diseases. It's 10% of the expenses towards distribution of the drugs. Some counties actually now procuring praziquantel for schistosomiasis as part of their essential drugs. So we are beginning to see recognition of the fact that this is a county problem. We need to see more, where counties are deliberate in terms of allocating resources for the health of their own people. So we are now focused on domestic resource mobilization, which means just having conversations with county governors, showing them the burden of disease. And some of these diseases, like soil transmitted helminths, people really didn't think it was a big issue. When we were growing up, you have mignon, you continue. But when you begin to see how it affects learning, retention in schools and all those things, then county governments are beginning to appreciate the need to invest in them. We need to see more of that. We need to see more attention to water and sanitation. We have 11 sub-counties that still have trachoma. We can deal with this. We can eradicate trachoma in 2024. We can eradicate soil transmitted mignon. We can eradicate schistosomiasis if we are focused on prevention. And the key prevention areas for those diseases is water and sanitation. And
can we not really look at it? I'm sorry. Can we not have running water? Can we not have latrines? Can we not have treated boreholes that will have piped water? Can we not have treated pans? Can we not?
We can. What is the problem, City? Why the reader?
For me, it's the will. You know why? When you work with government entities, and you see the movement of the change of one head of a government entity, like say a county and another, and you see changes and you ask, did these people get a special allocation for funds? No, we get this allocation every year. So you start wondering, so what has been happening the other years if this allocation was available? Because this isn't a secret. That money is never used. Even though what is allocated first is never used for what it's intended. That's number one. Never. It is the reason why the Auditor General, year in and year out, keeps pointing out to billions of shillings, simply not being accounted for. The maths that I was doing about the 2,600 workers,
yes,
at 2,000 shillings, the sum total per month comes to 5.2 million.
Yes.
You're telling me a county that has a 6 billion budget cannot afford 5,200,000? Apana.
Come on.
Apana. That one, no. When you look at the travels that we keep talking about, they're in the hundreds of millions.
Priorities.
And precisely.
Yes.
So the question you asked, why I'm just summing it by saying the will. You see, if there's no will, there'll be no priority.
It's true.
Okay? There are people in the Ministry of Health whose area of specialty is costing.
Yes.
They can break this thing down to a T. So they know. It's not that they don't know. They do know. You have health economists who can prioritize these things for you and tell you and show you with great clarity what must be done.
What level of influence in decision making do those people have? Because it's the people who know
Yes.
are not the ones who make the decisions.
No.
They will pass in a paper and it'll be among the very many
They
other
do what
papers.
they're supposed to do and then they hand it over.
They hand it over.
And if the person who's making a decision looks at this and says, Mignon.
Nilikuwa na mignon. Nilikuwa narusha tu.
Or if I invest in Mignon, I'm insulting my people. You know, someone is looking at it politically.
Yes.
If I say we are running a Mignon program in my county,
Or jiggers.
people will be saying, ha. Iyo ni ile county ya Mignon. And the politician is not willing to be the one who's painted that way.
Yeah.
Or just not understanding and seeing the connection between the Mignon, the jiggers, and the disease burden. Or maybe they see it and they see that will make people keep coming and that will make me keep spending money on
people
cure.
in those positions of authority have a priority. They all want to become either millionaires or multimillionaires. They don't want to start businesses. They want to see how much they can pilfer. It's really not complicated. And everything they do, and that's why they put up buildings, because with buildings you can hype the costs. You can do all manner of things with it. And then they want to buy big equipment. Again, you can do all manner of things with it. And yet what you need is something so basic and which doesn't really cost that much. So, and then someone gives you an argument and says, you see, we're looking, man, you're given the runaround. Since independence, what we're seeing is a moving backwards. No, not even meeting the needs of what we have. You know, this community health that we talk about, there used to be people, public health practitioners who'd come around to make sure that malaria,
local health.
Yes, they're called extension officers.
But I think for me, as we move forward, if we focus on the right investments, we need facilities, we need hospitals. But if we focus on prevention, as City has said, we can deal with almost.
We'll sort out everything.
We'll sort out a lot of the health problems so that we focus on when they get to a hospital, how best can we attend to them without having everybody come to the health facility. If we can deal with what he said, 75% of the issues at the community level.
Things.
And the African Institute for Health and Development is really focused at community level.
Tops of our conversation this morning, Mary. Thank you very much for it. We've been talking about policy formulation for poverty, health and social protection with our guest, Dr. Mary Nyamongo.
What happened to Amuyunzu now?
Amuyunzu bwana.
Amuyunzu Nyamongo.
She's the founder, director and technical advisor at the African Institute for Health and Development.
This is the Situation Room, the only way to start your day.